Thank you so much for that overview, Peter. I'm going to see if there are any questions here in the room. I think that we've set aside 5 minutes for Q&A. I know, don't run away, Peter. Well, maybe while we're waiting for people to come up to the mic, I'll ask you a question myself. One of the things we've talked about a lot today is trying to cut through silos.
Yeah.
And there's so many different models out there. So, I guess my question for you is, how do we navigate, into, these new delivery models, sort of a new, better state, more optimal use of home care in a comprehensive kind of way that doesn't have the effect of setting up more silos?
Yeah. Well, so when I've been advocating for change back at my institution, where I'm heavily supported by our hospital, I tell the hospital CEO and the subspecialists there, they will not miss these patients that we carve out. They really won't. They lose money on them. They clog up the works. They slow down the clinics. They're not that great for the hospital. They won't miss them. So carve them out. Bring in the home health workforce that's already established. Train the aides better. Bring in the home health workforce who are seasoned in the field. Align the incentives. Use the existing infrastructure. But carve them out and pay for the team-based approach that you've advocated for here today so effectively, so that you're integrating a medical and social model around a group of patients that are driving a pretty substantial portion of the total cost. It does not make sense to try to push this out into the silos, and it certainly doesn't make sense to do it piecewise in time or with respect to the entirety of the care team that's required. So I'm saying carve them out.
Okay, I see a question at the mic.
Yeah, Jim Piles with the Academy. I was just on the phone with a reporter from New York Times who did the front page article on a father's dying wish to die at home. She asked me the question of, gee, love that independence at home model, but how does it supply, or does it supply the care that a terminally ill or chronically ill patient may need on a 24-hour basis? How do you address that issue?
24-hour basis. So the only people that are usually in the home 24 hours a day, unless you're Bill Gates, is the patient and their family. And then depending on how poor you are, you may have an aide in there for 8 or 10 or 12 or 16 hours. The answer is you have to bring everybody together. If it's really a person that needs 24-hour care, whether they're in hospice or in this period of time before you've quite made it to hospice, you haven't quite qualified for hospice, but you're very ill and destined to die, the care process is supported always by a constellation of friends and family, neighbors, a certain amount of paid aides coming in from whatever source you can scrap together using the different financial models that exist out there. It is, in each case, it's like each one is a unique work of art, right? You're constructing a care plan that you pull in what you can find and put it together and do the best you can. Not always perfect. It's certainly not great, but it's the best you can, and that's how we do right now.
Okay. Thank you, Peter. I'm going to go ahead and call up our next panel, and I actually have us 2 or 3 minutes ahead of time, so we've made up considerable time now. So I'm going to call up our next spate of panelists, and I want to just note that I'm not going to be able to give really long introductions to these folks, but they are truly luminaries, and so I encourage you to look at their bio sketches, which the IOM has kindly provided today. So panelists, come on up, and I'll introduce them from that mic over there.